All right.
Billy, number 6.
Number 6. Now, on my notes, you can see them. I have next to this article.
He does.
Oh, God, just shoot me now.
Oh, yeah.
So this is going to be beefy.
We apologize.
And you know it's going to be beefy. As soon as someone starts with I have an issue with that, you know that that's not going to be a simple problem.
And then tie that with a policy.
And then tie that with a policy, and then finally nest it with pulmonary embolus.
And then you're just hosed completely.
And so here we are, issues in adults with suspected pulmonary embolus, and let's launch. So this is the ACEP Clinical Policy Group. It's a big group of people. Fessmeyer was the chair of the committee, and there were, I don't know, some 20 people or so involved at least.
Mm-hmm.
And they're going to address some specific clinical questions related to PE. They state here that they do not attempt to be comprehensive, but let me reassure you,
I would have hated to see comprehensive if this
they'll
is
be
not.
more comprehensive than you wanted. All right, so what is the background on PE? We all sort of know it, we live it. Somewhere between 650 to 900,000 patients have a fatal or non-fatal PE acutely.
That's a
per
lot.
year. It's a lot. 200,000 are fatal cases, and they usually die right up front if they're going to die. Survivors can have significant morbidity, both cardiac and pulmonary, and the treatment agents are not a free shot. So unlike ACS, where you can admit it, treat all, and then rule them out, if you do that here, you hurt people with therapy. So this is sort of the quintessential medical nightmare. So there's going to be questions after questions, the usual ABC relevance in terms of how good the evidence is. And so question 1, do objective criteria, and I would mark objective, provide improved risk stratification over clinical gestalt in the assessment of a patient for PE? No level A or C recommendations, and level B is, thank God, either objective or gestalt clinical assessment, either, can be used to risk stratify patients with suspected PE, and there is insufficient evidence to support the preferential use of one method over the other, which means you could either skip the next 30 slides and say, I'm kind of a gestalt kind of person, and that's how I'm going to go, or we can go through them, and we are going to go through them, but the bottom line is going to be there for you. Never mind the fact that probably 30 people around the world have achieved full professor rank by publishing on this topic. Where did they get us? Almost to where Gestalt was. All right. Objective criteria versus Gestalt. We're going to go through them. There's the Geneva score. There's the revised Geneva score. The simplified Geneva score. There's the Wells score. There's the Klein, the Charlotte criteria.
See, there's all those professors.
There they are. There's the Pisa model. And all of these have sort of, they come out as a scoring system, then they sort of get simplified, and then at the final stage, they get to the PE likely, PE unlikely.
Revised.
So that's sort of where we're
Revised and simplified.
So we're going to drag you, as
briefly,
the committee did, through these.
We'll dip you lightly.
I wish that was the case.
Yeah, I know. We'll try.
Okay, so let's start with Geneva. Described by Wiki in 2001, score from 0 to 16, 8 parameters. Here's how you get it. And it included blood gas and chest radiograph, which is not so good.
That proved to be a problem.
That was a problem, so then they ditched it. And so they got rid of those, came up with the revised Geneva score, now 0 to 25 with 8 parameters, and you get these scoring systems. And I want to point out a couple things. First off, in the low probability group, the risk of PE was still 8%.
Still high. Way higher than we'd be comfortable with.
I don't think a lot of people are comfortable with that. So that's, to me, it's like, okay, it might work in Geneva, but that ain't going to fly
didn't
here.
Work there.
So different elements had different weights, and so that takes you to, you've got the Klein rule and the Geneva rule. Let me introduce you to Mallon's rule. Mallon's rule is very simple. If a scoring system has variable weights, it's prima facie evidence of data torture, and the rule doesn't work. That's my statement on it.
There you go.
But we'll tolerate it for a little bit here. Additional versions divide the patients into 2 groups. As I said, we're going to get to that, PE unlikely and PE likely. And in the PE unlikely group, 11%.
That's too much.
Rate of PE, still too high. So I don't find this one, and this is not about my opinions, clearly. This is about learning for the LLSA, but I find that a little bit problematic. And in the PE likely group, it scores 3 to 7. The risk of PE, probability of PE is 35%.
Yeah, this one didn't shake out very well.
All right, so we're still asking the question, objective criteria versus Gestalt. Has the Geneva score been validated? As I mentioned, lots of people have been publishing on these things, so it has. Both the Geneva and the revised Geneva and the simplified revised Geneva have been validated.
Meaning that you can use it, and those numbers we just talked about,
which we didn't
bear
like
out.
so much, bear out. So here's some of the stuff to look at with the revised and the simplified Geneva. The simplified Geneva, as you can see, is 1, except for heart rate greater than 95. They had to do a little data torture to get that one to work. But that starts
they divide
to
the heart rate into two different groups, too,
Right.
which is, it starts to get a little
Yeah.
strange.
So there you go. But at least there isn't anything in here like you thought they had another diagnosis,
Oh, you
which
think-
is
would that
hardly
come up?
objective.
Yeah.
That'll come up in a
That'll
moment.
come up. There's your revised. So
There's
this
your
is
revised
basically the numbers
scores, and
how
that's
they
what you
all
get.
Shook out.
And so again, as we said at the lower end, you got the 7.9%
Too high.
too high, and that's more than a third of the patients. Ouch. Okay, so if we start looking again at this, you'll see some other alternative interpretations where we do the PE unlikely and PE likely thing, 0 to 2 for unlikely, 3 to 7. And the unlikely group has...
That didn't make it any better.
Right. The unlikely group is 65% of patients, though, so theoretically, if I then went after them with a D-dimer, maybe...
If that would work.
If
So
that was
but
good.
they didn't test that.
Right. They didn't test that, but maybe that would be a way to go, and we're going to talk about where to apply the D-dimer. Now we go to Wells. The initial Wells algorithm approach proved unsuitable for use. It retooled to use 7 variables, and you get this sort of a table where the low-risk group is a little bit lower, 3, and that number 3 to 3.6%. We're going to find at the end of all this,
Keeps dropping out.
yeah, you can't do much better than that. So no matter how smart you are
If you
from
try
Boston,
to do it objectively, that's what you're stuck
3%
with.
are still going to burn you. So, again, they do the PE likely and unlikely thing with the different scoring tools. Here again, on the unlikely group, because they included 0 to 4, you
Yes.
start getting up to
Still
7.8%. Which is why, in the end, as we said, Gestalt is going to do almost as good as this stuff.
Although this does mention at this point the D-dimer did get thrown in at this point in this paper, looking at sort
Right.
of the use of that. And you can drop that less than 8 down to less than 2 by throwing in a D-dimer, and that'll come up again more later too.
Right, and less than 2 would work for me. So in the Wells score, here you have it. Again, you see the variable points, and remember Mallon's rule, if they got variable points.
Especially half points.
Yeah, especially half points. And then they have this thing that they want to pretend is objective, which is an alternative diagnosis is, less likely than PE or more like, so you can go on either side of that. And that's just not that
hard.
objective. That requires a whole nother bunch of gestalts. So here's some of the interpretations of how it goes and how you can use it, and you can see how this graph breaks out. It's actually not that different from Geneva
really
when you run it
isn't.
all through. So in the low group, PE unlikely, it's 7.8%, and that's
It's
a little
almost
more than
3/4 of people.
yeah, almost 3/4. So it's a little more people. That's good. So, as I noted, the criticism, the use of subjective criterion, not so good when they added an alternative diagnosis. It also gives 3 points for that particular part of the score.
Right, and the cutoff is 3, so it's a game changer.
Right, so as a sole criterion, it either makes or breaks. So, yes, it has been validated, but it's got that little issue with it. Now we go to Dr. Klein, and his decision rule. Goal was to select patients in whom a negative D-dimer, so now we're beginning to upfront integrate this in, would reliably exclude PE. Wanted to create a decision rule that would categorize 80% of patients as safe to exclude PE with
Using
the
the
D-dimer.
D-dimer.
Right. So 6 variables, they constructed it to determine which patients and get the PE risk less than 2%. So what is the unsafe patients? Age greater than 50, you got to do a shock index.
What
Plus,
this means is people, you can't even use the D-dimer to
Right.
start. That 20% that he's trying to,
Right.
that just won't even fit into this.
yeah, so you can't even go there. And any of those 4, unexplained hypoxemia, unilateral leg swelling, recent surgery, or hemoptysis.
And you have to use this because otherwise you can't apply this rule. You have to start here, and then you can go to this
And
rule.
some of the errors are that people don't start here. They just start
Right.
applying the rule, but they haven't done the entry
And
step
the rule
first.
doesn't fit because if you apply that to the 20% that fall out, it is completely inappropriate
Yep.
as far as
Won't
you don't
work.
get anything like
Won't
these
work.
numbers.
So, determines which patients in whom it is safe to start ruling out PE, and you can start with the negative D-dimer, and that test alone would do it. We have this complicated graph here, which you can follow. and I'm not going to take you through each
No,
individual
a lot of
step.
these things are on your smartphone. If you have smartphones, there are programs that do this for you. Just click, 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 and it'll say yes or no, use it or don't.
Or in my case, on the resident's smartphone.
Yes, because he doesn't have one,
I'd hate to be outsmarted by my phone.
which happens all the time.
It would happen. Okay, so now we're continuing to look, and if the D-dimer has a negative likelihood ratio of 0.07, so that's an assumption, that depends on which platform of D-dimer you're using, et cetera. But if that works, if that's true, then the rule will decrease the post-test probability of PE to 1%, which would be good, but we don't have any prospective outcome studies saying
No.
it works. So he did some analysis on his own
But it hasn't been put out
prospectively
no,
done.
and it does decrease scanning. I guess
Which
that's
is good. No, that's very good. And we're going to talk about the PERC rule later, which is also very
Although it
good.
would be nice to know that it decreases scanning and still sticks to that low probability of PE.
Right.
We don't
So we'd
really
like to have this
know that.
prospectively run out. It's good to know that someone else can get to the full professor rank doing that. Now we get to the Leaning Tower of Pisa model. This is a mathematical model for predicting PE, 10 characteristics. So as soon as you say that, I'm not happy.
Mallon's rule. It's Mallon's corollary.
And with 10 criteria, they also have this looking for radiographic signs of oligemia. I'm fine. You want to talk Hampton's Hunt or a Stark Westermark's cutoff. But if you want to talk about regional oligemia, then I have to pretend to be able to see the vessels throughout the lungs. And I'm not good enough to do that, even though I've looked at a lot of chest x-rays. So this has a high reliance on chest x-ray findings, and as Di noted in the slide set, it's beyond the skill set of the average physician. I'd say it's beyond the skill set of most to do that, certainly with any inter-rater reliability. So the revised Pisa model, so again, we're going through this step by step. Everyone comes out with the big thing, then they revise, and then
Go
they
back and
sort of
fix it.
simplify. Coefficients add up to a score, and then they calculate it. It has been validated, but it's too cumbersome for me.
It is. It's really
too
hard.
cumbersome for me. Now, if you want to look at these scoring systems, they perform sort of well, but they're difficult to compare to each other directly, hence the seesaw with an apple and an orange. Studies show differences between them that, some of it comes out in design flaw, some of it comes out in sample size, some of it comes in who's enrolled, the ages, et cetera. So these papers are really hard to compare side to side and criterion to criterion and score to score.
But each does come out with numbers that are very similar to each other's. So even though comparing them head to head is difficult, they tend to be sort of lockstep as far as at least the low risk, which is what we're the most worried about.
Or most interested in because it allows us to move, to reach a disposition. So, Gestalt clinical assessment based on a clinician's training, clinical experience, and judgment. Imagine that mattering. Physicians divide patients into group low, intermediate, and high. And in PIOPED, physician Gestalt performed pretty well. So the educated guess, is this really what you're worried about? And when you compare Gestalt to the scoring systems, they both do pretty well. And in all studies, however, Gestalt and the scoring system still are going to miss, if some are going to say, 2%, 3%, but it's 3% is the number that really keeps coming out. 3% is it. And so basically one of my take-homes from this is, I don't care how good you are, what scoring thing you use, how you do it, you're going to miss 1 in 30. So lots of inter-rater reliability issues with these. Clinical experience varies across patients, lack of familiarity with the rules. I certainly, I'm so relieved that Gestalt did well because I just didn't want to be knowing all these rules or even knowing a few of them. And so poor spontaneous recall of the rules is an issue. Hence the smartphone. Thank you. So their conclusion, and this gets me 2 thumbs. Those are the longest. Did you stretch those thumbs out?
I did not. They came like
Those
that.
are some long thumbs,
Yeah.
but there are 2 of them, and they're thumbing up, and that is that objective criterion and Gestalt perform equally well.
Thank goodness.
Thank you. And, if we go back to sort of that idea, and this is something that lots of people have said, when you start looking at decision rules and sort of how to go about these things, the Ottawa ankle rules are great because you're interested in a very focused question on a very straightforward anatomic topic, and the creation of a rule that would decrease x-rays will work.
That's easy to use.
That's easy to use. You get to things, and you can do it with C-spine. We've seen that. But as soon as you get to things like syncope or PE or a bunch of other things where there's a lot more stuff in the pie, the question is whether you can really do that.
Right. A lot of people spend a lot of time Yeah, they haven't borne out well. Most
No.
of these decision rules, when they finally get applied, don't really
And as soon as you
work.
see one on a confusing topic like that sounds great, just wait for the next few papers. Because they always sounded great initially. The initial blush of enthusiasm in these fades relatively fast. On top of which, because in this particular case there are multiple different people with their own angle on it, they also intentionally rain on each other's parades. So there's a little bit of that sort of academic, pissing contest stuff goes on as well. So eventually the luster comes off. All right, so now we're going to move on to the PERC rule, which is a different kind of animal. The PERC rule is about saying you need no tests.
Yeah, you're done.
It's not a PE. So no level A or C recommendations, but the level B one is that in patients with a low pretest probability, Gestalt or score,
Crucially important.
in patients with a low pretest probability for suspected PE, consider using the PERC rule, which I would also have to say means consider not using it, to exclude the diagnosis based on historical and physical exam data alone. So what is the utility of PERC? And Klein developed the rule to exclude PE, followed them for 90 days, and found that it worked pretty darn well. And here's the rule: 8 variables, known as the PERC rule: age less than 50, pulse less than 100, SATs greater than 94% at sea level. I guess you could adjust that for Denver. No unilateral leg swelling, no hemoptysis, no recent trauma or surgery, no previous DVT or PE, and no hormone use. If they meet all criterion, they're PERC negative,
Right,
and
this
you
isn't
are done.
All or none, though. This
Right.
isn't their heart rate's 99.
You can't hedge.
Technically, that doesn't fit.
Right.
So this one, you have to hit all 8.
Right. All right, so what is the utility? And the patient's got to be low risk first, as Diane pointed out. And when studied retrospectively, as Klein did when he looked at this, was Klein? Yes. 25 to 30% of the patients were PERC negative, so it's a big
That's a
chunk.
lot.
That's useful. Had a 1.4% false negative rate, so about as good as you're going to get to anyway.
Yep.
We said you're going to get to 2 to 3% is the best you're going to get, so you got there with this. But there's no prospective study. He looked back
Yeah.
at his own data set where probably the data fidelity and the data points were more solid. It's, that needs to be shown that other people can get those same kind of numbers. What's the role of a D-dimer now, we're going to ask, in testing for the exclusion of PE? And the level A, so this is really the first level A evidence we're
Finally.
seeing, in patients with a low pretest probability, a negative D-dimer means you're done. Level B, none. And level C, in patients with an intermediate pretest probability for PE, a negative quantitative D-dimer may be used to exclude PE. Now that's getting a little dicey.
In a diagnosis that can kill you.
That's
that
a
one's
lit-
getting a little bit out there.
That's a little dicey, but considering we've been all over the dartboard with this over the years, maybe we're there, and I appreciate the committee for having the cojones to reach that conclusion.
If you don't speak Spanish, I'll let
There
you
we
look
go.
it up.
So, D-dimer is sensitive, but only moderately specific. Everyone knows that. Pretest probability of PE is crucial. In low probability patients, a negative D-dimer puts the risk around 1%. Darn good, I'll
even
take
better.
it. In intermediate probability, where they were stretching a little bit, the risk ranges from 1 to 5%. 1 I could live with. 5% is getting into that zone where it gets a little tough. D-dimer cutoff, we're going to say, how high is the D-dimer? Instead of using it as a binary
Which
yes-no thing.
this is a big push in the literature right now.
Right?
Yeah.
So now treat this as a continuous variable. How high is the D-dimer? Those cutoff studies might help narrow risk, but we don't know enough about them yet.
No, in fact, really don't. So I wouldn't bet the farm on those at all yet.
And you would be betting at least the farm. All right, so what is the role of CT angiography of the chest as the sole diagnostic test? For PE, no recommendations, level A. Level B, for patients with a Wells score less than or equal to 4 who require additional diagnostic testing, a negative CTPA alone is done.
Right. And the problem with this is that they only can make these recommendations based on studies, and the studies haven't really looked at Gestalt as well. So we just said Gestalt and scores are pretty good, but they can't say that for sure because that wasn't specifically addressed.
And now level C, again stretching a little bit, for patients with a high pretest probability and a negative CTPA, perform additional diagnostic testing. And I don't think anyone would argue with that one. Unlike the last level C one, which I felt was a bit of a stretch, I think people would buy on this, whether you go to the lower extremities or VQ
Right.
or...
If you're sure it's a PE and that CT doesn't show it, you still have to do something.
Yep. So CTPA sensitivity, 89 to 100%, and it's gotten better with better scanners, better as radiologists have gotten more comfortable doing it.
But not 100%.
Not 100% generally speaking. Clinical outcomes of PE unlikely patients with a negative CTPA show a rate of PE of 0 to 2%. We're back
Pretty
to that.
good.
We keep coming back to that. Clinical outcomes of PE likely patients, rate of VTE as high as 17%. Therefore, the recommendation for additional testing. All right, what about looking at the legs? So we got this ultrasonographer up there looking at the legs. And should we do that? What's the evidence for that? Level A, none. Level B, when a decision is made to perform a venous ultrasound as the initial imaging modality, a positive finding in a patient with symptoms of a PE can be considered evidence for the diagnosis of VTE and may preclude the need for additional testing. So a lot of people are focusing on maybe going here first and trying to save some CTPAs that way.
Right, and this basically says if they have shortness of breath or pleuritic chest pain and you find a clot in the leg, you can just say, yes, they very well could have had a PE, but I'm done.
Smells like a clot, looks like a clot, they got a clot down there, I'm calling it a clot in the lungs. What's the role of venous imaging in the evaluation of patients with suspected PE? The level C thing they offer up for patients with an intermediate pretest probability for PE and a negative CTPA, so you weren't going to stop there. A venogram, a CT venogram has not been performed. Consider lower extremity venous ultrasound.
Right, and this goes to kind of goes back to this. You notice it says intermediate, not low likelihood, high likelihood. So they can only base their recommendations based on how it was published. So these data were published based on low, intermediate, high probability, not likely, unlikely.
Right.
So we're mixing a little bit of apples and oranges in how you approach this, but this is the best they can do based on the published literature to date.
And the second level C recommendation was in patients with a high pretest probability of PE and a negative CTPA, so you're definitely not done, and CT venogram has not been performed, perform an additional test and consider ultrasound as that test.
Right.
So ultrasound, going to the legs when you're stumped, seems to be a place to go. And granted, the evidence isn't the strongest, but I don't think that's that hard of pill for anyone to swallow.
Right.
Yeah, I think that's logical. All right, now, what is the role of venous imaging in the evaluation of patients with suspected PE? And here we sort of have a final statement on this. A positive venous ultrasound in patients with good symptoms for it diagnoses it. Not adding a CTPA in symptomatic patients decreases radiation, so going there first might go.
Not bad.
And CT venous studies of the lower extremity ultrasound appear to be equally useful in diagnosing the lower extremity.
Right, but add the radiation.
Yep, and you add the radiation. And dye, too, to a certain degree, because you need more dye to run off to do it if you're going to do the CT version. All right. What is the role of venous imaging in the evaluation of patients with suspected PE? So the lower extremity ultrasound first, to avoid all the radiation, is most useful in who? Patients with obvious signs of DVT, pregnant patients where a gravid uterus is going to slow venous drainage from the legs and might get you there, and then obviously people who you can't do contrast on who are going to be a problem to or because of their nephropathy or allergies or whatnot. So patients with a negative CTPA but a high pretest probability for PE. So again, you went to the CT, it wasn't there, but you weren't, you were a dog with a bone, you weren't going to let go of it because they were high probability, will have positive venous imaging about 6% of the time. It says 0 to 6, but it's closer to 6. And that'll pick up those additional patients despite the negative CTPA.
And they may not be symptomatic, which is the other thing to convince your radiologist sometimes is that, what's the symptomatic leg? Neither. You're doing both.
Right. Yeah, they do.
Pick a leg.
Pick a leg. No, I'd actually like to improve the yield by looking at both legs. And also, you have to remember that for some of the pregnant patients and others, these may be very proximal and going into their pelvic veins, so both might be the way to go. All right, what is the role of venous imaging in the evaluation of patients? What are the unanswered questions? And here's a couple. Is venous imaging warranted if the negative CTPA is using a multi-detector scanner?
Right.
The implication being that the multi-detectors might be good enough. I don't think that's going to be true. So I'll offer my opinion to that unanswered question. But the authors from the committee say that answer doesn't exist. You can have your opinions, which I just offered you mine, but the answer isn't out there. And which patients may benefit from adding venous imaging to CTPA? So
They don't know.
They don't know.
They don't have.
They don't
They
know.
don't have the answer. To
they
that.
don't know. And, but it's certainly a reasonable thing to do when you're stumped.
Mm-hmm.
All right, so now we're going to go from, that's all the diagnostic side, lots of rules, Gestalt, the PERC rules. Yeah. Now we're going to move to the next topic, which is treating. Who gets thrombolysis for a PE? And generally the concept here is you don't treat a PE with thrombolytics unless they're trying to die of that PE or have significant resulting morbidity. So they got to be sick. So level A evidence, none. Level B, give thrombolytics if they're hemodynamically unstable with a confirmed PE for whom the benefits of treatment outweigh the risks.
So there's three major things there. They're unstable, you've diagnosed that PE, and you've decided it's worth it in the big picture to go ahead and do this.
And the three things are not that delineated. So confirm the PE how?
No, it doesn't say. Right, exactly.
Right. All right, in centers with capability, you might also elect to do surgical or mechanical thrombectomy as an alternative to lytics. In other words, if you can get that done promptly, that would be the way to go.
Right.
And you might have, and the reason would be is that although this surgical or mechanical thrombectomy has its set of risks to it, they might be less than thrombolysis given the patients you're dealing with. So you got to ask those questions. Certainly in someone who has high risk for bleeding or had a previous hemorrhagic stroke, you'd be wanting to go that way. Level C is consider thrombolytic therapy in hemodynamically unstable patients with a high suspicion for PE. So a young pregnant woman has a syncopal episode or a cardiac arrest and gets brought in. You're not thinking that she's an MI.
Right.
You're thinking she's a PE. So you might consider lytics in her as an attempt to get it back.
Because you're not going to send her to the scanner.
You're not going to send her to the scanner.
You can do bedside ultrasound.
Right.
But
And level C, at this time, there is insufficient evidence to make any recommendations regarding the use of thrombolytics in hemodynamically stable patients. And we've seen that pendulum sort of swing. Now, it used to be in the original version, if you go way back, in the Wayback Machine, who got lytics? You had to have a traditional angiogram confirming it, and you had to be in shock, hypotensive. That was the
coding.
Or coding. And they would give you, I think in the original papers, it was urokinase. Then they liberalized them to include, we would consider thrombolytics in even people with persistent tachycardia and right heart strain. And although the data wasn't great, some of those seemed to do worse overall. So they said, no, we really mean unstable, hemodynamically. So although we haven't strictly defined what hemodynamically unstable is, we know that if you go too liberal with that, you're on the wrong side of the cutting edge.
Right. I like this because this comes up not infrequently. When should you be lysing? And if they're stable, you don't.
And obviously I'll pull the trigger on this occasionally. Oh, and remember that the dose is higher, right?
Yes, right.
For heparin, the dose is higher for PE at 18, and for lytics, you got to give a good slug. So what are the indications for thrombolytic therapy in patients with PE? Studies highly variable in quality. You can imagine how hard these are to do. In a way, you would need to have a waiver of consent, which means that a lot of those studies aren't going to be from the United States. Most didn't study mortality as a primary endpoint, and when studied in hemodynamically unstable patients, the use of thrombolytics decreased combined endpoints, so you always got to worry about those, combined endpoint of death and recurrent PE, 9% versus 19%. So you got to break those down as to which of the combinations are counting for the bulk to sort of know what to do with that, but there you go. In terms of specific subgroup data for treatment with thrombolytics in patients with right ventricular dilatation on echo show no decrease in mortality. So when you liberalize this up to right heart strain, if you don't see a decrease in mortality, then you're all on the risk side for the thrombolytics. So that gets to be a problem. No improvement in mortality when using thrombolytics in patients with a right heart thrombus on echo either. So now we're kind of although it's not directly saying it, we're almost back to saying that hemodynamically unstable means shock, means hypotensive. That right heart strain, clot in the right heart strain by EKG or by echo.
Right. It has to be clinical.
Doesn't really get you there.
Yeah.
Right.
Affecting the patient directly.
We'll continue on with what are the indications for thrombolytics in patients with a PE, and you got to determine the risk-benefit ratio. So the risk of PE mortality can be determined using the PESI, the Pulmonary Embolism Severity Index, and we have this on the coming slide. And you got to remember that the risk of intracranial hemorrhage from thrombolytics is 2%, and the mortality rate is 0.5%, and major bleeding can be as high as 21%. So that's a pretty substantial risk. So you got to know how to do this. And here's the Pulmonary Embolism Severity Index, and you can see how the scores work out. I don't know if well, I do know. I don't actually calculate this out.
I don't either.
I make a decision based on, I really think the patient's dying of this PE. That my treatment algorithm isn't to prevent the next PE. It's that I got to do something about this PE.
Right. I think the main utility of this is that you are able to know the downside of the thrombolytics and be able to somewhat quantitatively weigh it against the downside of the PE for the patient. And if the downside of the PE is more than the downside of the thrombolytics, it makes you feel more comfortable, even perhaps someone who's really sick, underlying sick, that you would still go ahead and consider.
And I guess what I just said is that although there's no data to support it, I use Gestalt to make that decision, just like the other stuff. So the summary, and there's going to be a lot of summary slides here because this was such a wide-ranging, and this is going to have questions on it.
And lots of questions.
And it's an ASEP policy group, so it's you know that this is going to be
a huge issue we deal with on a frequent basis.
So Gestalt scoring systems performed equally well in risk stratifying patients. Thank God. PERC can be used in low-risk patients to exclude it based on the diagnosis of PE based on H and P alone.
Right, low-risk patients.
Loving it.
Key to
Those
that.
are good. I like that page. A negative D dimer can exclude PE in low-risk patients. Like that, a low-risk patient in low-risk patients needing a study, a negative CTPA means you're done.
Finished.
I can live with that. In intermediate risk patients with a negative CTPA, consider additional diagnostic testing, and I would maybe even be stronger there.
Ultrasound.
In high-risk patients with a negative CTPA, you got to go somewhere else. A positive lower extremity ultrasound precludes the need for further testing. If everything else smells like a PE, they got it. Give thrombolytics or perform thrombectomy in hemodynamically patients with a documented PE, people who are dying now of the PE you found. Consider thrombolytics in hemodynamically unstable patients with high clinical suspicion for PE who you can't go further with the diagnostic workup either because they're too sick or because you got to move faster.
Perfect. So there's a lot of meat in that. It's actually a pretty nice review to give you and things you can actually now do and feel good about.
Yeah, and I also think that and the reason I'm happy that this group did the work that they did at ASEP to come up to revise this policy is that I think that it's gotten a little as messy as the topic is. It was a good time to do it because some of the stuff got simpler. Got more straightforward. We had enough data to get to some pretty good summary points that we just looked at that can make this a more manageable topic than it was. 10 years ago, this topic was unmanageable in terms of what was going on.
Right.
And I think it got better, so it was the right time. And so my thanks to the group for doing the work. I'm not so happy I have to do an LLSA on it, but there you go.